Hi, welcome back to your prescription for medication education. My name is Yenmi, and I'm a pharmacist, and I'm here to bring you quality information regarding medications and health-related topics. And today's topic will be about calcium channel blockers. Just like last time, I'll start off the video with 5 questions. These questions aren't difficult, they're just thrown in here for just a little bit of fun. Question number 1: a 68-year-old patient with hypertension and chronic stable angina is started on verapamil extended release. 2 weeks later, the patient developed dizziness and near syncope after a cardiologist adds metoprolol succinate. The heart rate is 38 beats per minute, and the ECG shows high-grade AV block. Which mechanism best explains this interaction? Question number 2. A 72-year-old patient with atrial fibrillation is taking digoxin. Diltiazem is added for additional rate control. A week later, the patient reports nausea, anorexia, and yellow-green visual disturbances. Which pharmacokinetic change most likely contributed? A patient with hypertension is switched from hydrochlorothiazide to amlodipine. 3 months later, they report progressive bilateral ankle swelling that worsened at the end of the day. BNP is normal, lungs are clear, and there are no signs of fluid overload. Which explanation best accounts for this adverse effect? Question number 4. A 59-year-old patient with hypertension is prescribed extended-release nifedipine. The pharmacist counsels the patient to avoid grapefruit juice. What is the best rationale for this recommendation? And the last question: a 66-year-old patient taking apixaban for atrial fibrillation is started on verapamil. 2 months later, the patient presents with melena and a drop in hemoglobin. Which statement best explains why this combination may increase bleeding risk? Let's do a quick refresher on the role of calcium and muscle contraction, with a focus on vascular smooth muscle. Contraction in vascular smooth muscle can occur due to mechanical, electrical, or chemical stimuli. Membrane depolarizations opens voltage-gated calcium channels. There are several types of voltage-gated calcium channels. The voltage-gated L-type calcium channel is the dominant type of calcium channel present in cardiac and smooth muscle. The L stands for long-lasting, which refers to the length of activation. The L-type calcium channels consist of a pore-forming alpha-1 subunit with auxiliary beta, gamma, and alpha-2 delta subunits. An increase of free intracellular calcium concentrations from either the extracellular fluid or intracellular storage sites leads to contraction. The free calcium binds to calmodulin, which is a calcium-binding protein, creating a calcium-calmodulin complex. This complex then activates myosin light chain kinase, which is an enzyme that phosphorylates myosin light chains in the presence of ATP. The phosphorylated myosin light chain allows the cross-bridging between myosin heads and actin filaments, which causes contraction of the cell. There are several second messengers involved in this process that can increase or decrease muscle contraction. IP3 increases intracellular calcium release. Cyclic AMP inhibits myosin light chain kinase to promote relaxation, and Rho kinase enhances contraction by inhibiting myosin light chain phosphatase, which dephosphorylates myosin light chains. These pathways are regulated by G protein coupled receptors, activated by compounds such as norepinephrine and angiotensin II. For cardiovascular conditions, the L type of calcium channel is our target. Calcium channel blockers, as the name implies, reduces calcium influx through the L-type channels instead of interfering with its intracellular actions. Calcium channel blockers can be divided into two major subclasses, which are dihydropyridines, of which there are many, and non-dihydropyridines. The term dihydropyridine refers to its chemical structure, which is a 1,4-dihydropyridine ring. A pyridine ring is a 6-membered aromatic ring containing one nitrogen atom. In a 1,4-dihydropyridine calcium channel blocker, positions 1 and 4 are saturated, meaning the ring is no longer fully aromatic. Non-dihydropyridines consist of verapamil and etripamil, which are chemically characterized as phenylalkylamines, and diltiazem, which is considered a benzodiazepine. Regardless if they are classified as a DHP or a non-DHP, calcium channel blockers all bind to the alpha-1 subunit of the L-type calcium channel, but the distinguishing feature is that they bind at different regions of the alpha-1 subunit. This feature makes them pharmacologically different from each other. DHPs bind to the external lipid-facing surface of the pore and act as allosteric modulators, which stabilizes the inactivated conformation of the channel, which is not open in response to depolarization. I didn't mention this earlier, but calcium channels can exist in three states: resting, open, and inactivated. In the open state, calcium can enter the cell. In the inactivated state, the channel cannot reopen until it returns to the resting state. The reason I mention this is because dihydropyridine calcium channel blockers have a higher affinity for the inactivated state of the L-type calcium channels. This is clinically important because vascular smooth muscle channels spend more time in the inactivated state at resting membrane potentials compared with cardiac channels, which explains why DHPs produce greater rates of dilation with minimal direct cardiac effects. In contrast, non-DHPs bind within the central cavity of the channel pore, physically blocking calcium ion conduction. These agents affect both cardiac and vascular L-type channels, leading to reductions in heart rate, slowed AV nodal conduction, and decreased myocardial contractility. Among the non-DHPs, verapamil exerts a stronger effect on the AV node than diltiazem. Examples of calcium channel blockers include nifedipine, amlodipine, and diltiazem. Over the next couple of slides, I'll review a handful of them. In terms of blood pressure lowering effects, standard doses reduce systolic blood pressure by about 9.5 millimeters and diastolic blood pressure by about 6 millimeters. Calcium channel blockers respond well to dose increases and demonstrate a strong and predictable dose-response relationship. DHPs are more potent than non-DHPs for systolic blood pressure reductions, which is due to their vascular selectivity discussed in the previous slide. A JAMA review reported systolic blood pressure reductions of 15.9 millimeters for DHPs versus only 4 millimeters for non-DHPs. Adverse effects for DHPs include peripheral edema, gingival hyperplasia, and headaches. And for non-DHPs, adverse effects include bradycardia, nausea, and constipation. Contraindications for DHPs include STEMIs with short-acting agents, hypersensitivity to any of its components, and severe aortic stenosis. Contraindications for non-DHPs include second and third degree AV block, sick sinus syndrome, and severe heart failure. Warnings for DHPs include hepatic impairment, hypotension, GI strictures, and withdrawal. Warnings for non-DHP include arrhythmias and the use in heart failure. The FDA approved indications include hypertension, chronic staple angina, and vasospastic angina for calcium channel blockers as a class, but non-DHPs also have a use for supraventricular arrhythmias. Nifedipine was the first DHP calcium channel blocker approved by the FDA in 1981. The brand name for its extended-release formulation is Procardia XL. Although it's available as an immediate-release formulation, it is not recommended for hypertension because it causes unpredictable, rapid blood pressure reductions, which has led to severe hypotension, strokes, MI, and death. Nifedipine has two ER formulations. One uses an osmotic release technology, and the other is a matrix-based delivery system. Both formulations are tablets and are available in the same strength, and are both dosed once daily. They do have different pharmacokinetic profiles, making them non-bioequivalent to each other. The formulation with the letter CC stands for CoCor, and it should be taken on an empty stomach because if taken with food, it shows a 60% increase in peak plasma concentrations. The osmotic release formulation has less peak-to-trough fluctuations, which can minimize reflex sympathetic activation. Patients should avoid grapefruit juice while taking nifedipine. Its drug interactions include CYP3A4 inhibitors and inducers. Nicardipine's brand name for its IV formulation is Cardine. Its IV formulation is available as premixed IV bags at a 0.1 mg per ml or 0.2 mg per ml concentration. It's also available in a 2.5 mg per ml concentration in a 10 ml vial requiring dilution. When used in a hypertensive emergency, it's dosed at 5 mg per hour initially, but can be titrated by 2.5 mg per hour every 5 to 15 minutes with a max dose of 15 mg per hour. It can be given via a central line or a large peripheral vein, and its IV onset of action occurs within 5 to 15 minutes. Amlodipine is the most widely prescribed calcium channel blocker, and its brand name for the oral tablet is Norvasc. It's available as tablets, an oral solution, and an oral suspension. The commercially available oral solution has been shown to be bioequivalent to the tablet formulation. Clinically, I couldn't find any meaningful pharmacokinetic differences between the approved liquid formulations and the tablets. The typical adult starting dose is 2.5 milligrams and 5 milligrams once a day. The maximum recommended dose per day is 10 milligrams. Its drug interactions include CYP3A4 inhibitors and inducers, simvastatin as well. One of amlodipine key pharmacokinetic advantages is its long half-life of approximately 30 to 50 hours. This allows for once daily dosing and provides some degree of dose forgiveness if a patient misses a dose. Clevidopine's brand name is Cleviprex. It is an IV oil and water emulsion available in a 0.5 mg per ml concentration, either in 50 or 100 ml ready-to-use vials. It's used in the treatment of hypertensive emergency. The initial dose is 1 to 2 milligrams per hour, and the dose is doubled every 90 seconds until you approach your intended blood pressure goal. As you approach your blood pressure goal, the dose is then titrated in smaller increments every 5 to 10 minutes instead. The maximum recommended dose is 21 milligrams per hour over a 24-hour period. There is limited data for its use past 72 hours. Careful attention should be placed on food allergies because it contains egg yolk and soybean oil, which also provides a source of calories in the form of lipids with 2 kilocalories per ml. One advantage of clevidopine is that it does not have significant CYP3A4 interactions because it's metabolized by esterases in the blood and extravascular tissues, and its metabolites are inactive. But patients on parenteral nutrition should have their total lipid dose adjusted. Moving on to our non-DHP calcium channel blockers, verapamil was first approved in 1981. Most brand name formulations have been discontinued in the US, and verapamil is primarily available as a generic. It's available in 3 oral solid dosage formulations as well as an IV solution. One of its ER capsule formulations, Verilend PM, is designed to be taken at bedtime to provide its maximum effect in the morning. Non-DHP calcium channel blockers are typically not used first-line therapy for hypertension unless there is a compelling comorbidity. The typical starting dose is 120 milligrams to 180 milligrams, dosed every 12 to 24 hours based on the ER formulation. Some extended release formulations should be taken with food, so you should refer to the specific product labeling. It's recommended to reduce the starting dose for patients with hepatic impairment. Verapamil has a high number of drug interactions because it's a moderate inhibitor of CYP3A4 and it also inhibits PGP. Let's talk about diltiazem. Why does it have so many names? The problem stems from diltiazem's extended release formulations using proprietary drug delivery technologies that produce different release rates, peak times, and dosing frequencies. Each manufacturer patented their own controlled release mechanism, which resulted in different FDA approvals under different brand names. Diltiazem has 4 distinct oral solid dosage forms. Even for formulations that have the same dosing frequency, such as Tiazac and Cardizem CD, which are both 24-hour ER capsules, have different release characteristics. Basically, what I'm trying to get at is that each generic is AB rated to their specific reference listed product and are not interchangeable. When switching from one formulation to another, it's recommended to follow up with the patient within 1 to 2 weeks to monitor their heart rate and blood pressure. Diltiazem also has a large number of drug interactions because it's also a moderate inhibitor of CYP3A4 and PGP. The last calcium channel blocker I'll review is etripamil, brand name Cardamyst. Although it's not indicated for hypertension, I included it in today's video because I didn't know of its existence until I created today's video. Etripamil is a short-acting, non-dihydropyridine L-type calcium channel blocker which slows AV nodal conduction, designed as a nasal solution indicated for the treatment of paroxysmal supraventricular tachycardia. It comes with 2 disposable nasal devices and is intended for self-administration by the patient outside of a healthcare setting in the hopes it resolved the PSVT episode without the need to go to the hospital. Each single-use device delivers 1 spray in each nostril, so 2 sprays totals equals 1 full dose. The patient should be instructed to use 1 spray in each nostril during an episode of PSVT. If the episode has not resolved after 10 minutes, the patient should then use a new device and repeat the dose in each nostril. The patient should be instructed to seek medical care if PSVT persists 20 minutes after the second dose. In clinical trials, 64% of patients converted to normal sinus rhythm within 30 minutes of using etripamil with a median time of 17 minutes. The most common side effects were nasal discomfort, congestion, rhinorrhea, and throat irritation. Peripheral edema occurs with DHPs because they mostly dilate arterioles while having minor effects on the venules, which creates an imbalance. By dilating precapillary vessels, This allows more blood flow to enter capillary beds, which increases capillary hydrostatic pressure, pushing more fluid out of the capillaries into the interstitial space. This effect is more pronounced when the patient stands because standing increases the capillary pressure in the legs. Normally, the body compensates when we stand via a local sympathetic reflex, which causes vasoconstriction in the precapillary vessels to protect against gravitational increases in capillary pressure. DHPs interfere with this protective autoregulation. Edema is most noticeable in the ankles and feet because these areas experience the greatest increases in hydrostatic pressure due to gravity. DHP-induced edema is not due to volume overload, meaning diuretics are generally ineffective. Adding an ACE inhibitor reduces DHP-induced edema because they cause post-capillary dilation, which reduces capillary hydrostatic pressure. In a network meta-analysis comparing the antihypertensive regimens, the combination of amlodipine with an ACE inhibitor had the lowest probability of peripheral edema. The incidence for edema increases over time, so patients may not present initially with any complaints, but may experience edema months down the line. The incidence rate for DHPs is 12.3% versus 3.1% with non-DHPs. Gingival hyperplasia due to calcium channel blockers is due to reduced collagen degradation and increased extracellular matrix accumulation within gingival tissue. Calcium channel blockers are thought to reduce collagenase activity, including decreased expression of matrix metalloproteinase 1, an enzyme that degrades extracellular matrix proteins like collagen. This enzyme is expressed by fibroblasts found in various tissues. However, gingival fibroblasts have unique molecular signaling compared to fibroblasts found in other tissues. Calcium channel blockers alter calcium-dependent signaling pathways within gingival fibroblasts, and this does not occur to the same extent in fibroblasts found in tissues such as the lung, skin, or muscle. Risk factors for gingival hyperplasia include male sex, younger age, higher doses, duration of therapy, and plaque accumulation. Tissue enlargement typically begins 1 to 3 months after initiation and regresses within 6 months to a year after discontinuation. Nifedipine has the highest reported prevalence because it accumulates at higher concentrations in gingival crevicular fluid, exposing gingival fibroblasts to greater drug levels producing highly fibrotic lesions. Flushing and headaches with calcium channel blockers are due to arterial vasodilation, and it's more common in DHPs. The flushing is more common in rapid onset short-acting formulations. Dilation of blood vessels near the surface of the skin increases blood flow and creates visible reddening and warmth, which is the flushing sensation. The proposed mechanism for headaches include dilation of intracranial arteries, which can stretch pain-sensitive structures, and reflex mechanisms that trigger compensatory responses that contribute to headaches. The symptoms may diminish over time as patients develop tolerance. For non-DHPs, constipation is also a common side effect. Verapamil has the highest incidence of constipation, which occurs in about 7.3% of patients. Verapamil causes constipation by delaying colonic transit via inhibition of colonic smooth muscle contractility. In severe aortic stenosis, DHP use can potentially lead to profound hypotension, syncope, and myocardial ischemia. Normally, a drop in blood pressure triggers a sympathetic compensation to maintain our cardiac output. But in severe aortic stenosis, the fixed valvular obstructions limits the flow regardless of left ventricular contractility, so the compensation is blunted. In a retrospective study of 314 patients with moderate to severe asymptomatic aortic stenosis, found that calcium channel blocker use was associated with a 7-fold increased hazard ratio for all-cause mortality, independent of age, hypertension, left ventricular ejection fraction, and aortic valve area. Non-dihydropyridines are contraindicated in second and third degree AV block without a functioning pacemaker present. The AV node is unique because its depolarization depends primarily on calcium influx through L-type calcium channels rather than fast sodium channels, which are responsible for depolarization in atrial, ventricular, and His-Purkinje tissue. In second or third degree AV block, the AV node is failing to conduct impulses consistently. So when we add a non-DHP that further suppresses AV nodal function, this can precipitate a high-grade block and severe bradycardia. They are also contraindicated in sick sinus syndrome, Wolff-Parkinson-White syndrome with atrial fibrillation, and generally avoided in heart failure with reduced ejection fraction. Although rare, there is an FDA warning associated with extended-release nifedipine formulations that use an osmotic controlled-release oral delivery system, with the non-deformable tablet shell that can cause mechanical obstruction, basal formation, or ulceration in patients with pre-existing GI narrowing. The empty tablet shell is normally excreted in the stool, but in patients with GI narrowing, it can lead to serious GI complications. The complications include basal formation, which is an accumulation of multiple tablets, forming a concretion that can cause obstruction. The tablets can also adhere to the GI wall, causing pressure necrosis and ulceration. Both amlodipine and nifedipine are CYP3A4 substrates. Nifedipine is more susceptible to CYP3A4 interactions due to its higher first-pass metabolism. For nifedipine, grapefruit juice almost doubles the AUC and Cmax, which is why it should be avoided, but it's less of a concern for amlodipine. Amlodipine also happens to be a weak CYP3A4 inhibitor, which is why for patients taking simvastatin, it's recommended that simvastatin not exceed 20 milligrams per day. The FDA classifies inhibitors and inducers based on their effect on substrate AUC. Strong inhibitors increase AUC by 5-fold or more, moderate inhibitors increase AUC between 2 to 5-fold, and strong inducers decrease AUC by 80% or more. Inhibition occurs rapidly, within hours to days, while induction requires new enzyme synthesis and takes 2 to 3 weeks to reach steady state, and the induction effect washes out over several weeks after discontinuing the inducer. Verapamil and diltiazem are modern inhibitors of CYP3A4, they inhibit PGP, they suppress the conduction of the AV node, and they also are substrates for CYP3A4, which results in numerous drug-drug interactions. Both drugs and their metabolites form metabolite intermediate complexes with CYP3A4 rather than simple competitive inhibition, which inactivates the enzyme. This means inhibition increases over time with repeated dosing as metabolites accumulate. One of the most important interactions is with beta blockers. Because both drug classes slow AV node conduction, combining them can lead to excessive bradycardia, hypotension, or even heart block. The risk tends to be greater with verapamil because it has stronger effects on the cardiac conduction. Verapamil and diltiazem inhibit P-glycoprotein, which is a drug transporter that pumps medications out of cells in the intestines, kidneys, and liver. Another important interaction involves digoxin. When PGP is inhibited, digoxin concentrations increase, which can lead to digoxin toxicity. Because verapamil and diltiazem inhibit CYP3A4, they can increase statin concentrations and raise the risk for myopathy or rhabdomyolysis. Diltiazem increases simvastatin exposure by 5-fold and lovastatin by 3.6. Limit simvastatin to 10 mg daily and lovastatin to 20 mg daily when co-administered with verapamil or diltiazem. The last type of interaction I want to mention is with the use of direct anticoagulants such as apixaban and rivaroxaban. Both diltiazem and verapamil increase DOAC concentrations through dual inhibition of CYP3A4 and PGP. A 2025 meta-analysis of 6 real-world studies found that concomitant DOAC therapy with diltiazem or verapamil significantly increased major bleeding risk and gastrointestinal bleeding compared to DOAC monotherapy. The answers to the questions at the beginning of the video are 1 alpha, 2 bravo, 3 bravo, 4 bravo, and 5 bravo. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, please consider subscribing and sharing my channel. Thank you. Have a great day.